Good afternoon, everyone. My name is Samuel from HGH Department of Patient Liaison Service. Thank you very much for joining us today. I will be assisting with the running of today's event. Today's webinar, Happy Hours, a Men's Health Talk, is jointly organized and presented by 4 departments of HGH: the Department of Gastroenterology and Hepatology, Department of Hepato, Pancreato, and Biliary and Transplant Surgery, Department of Otolaryngology and Head and Neck Surgery, and Department of Urology, to celebrate Men's Health Awareness Month, which is this November. Our 4 speakers today will discuss with you in more detail about 4 health conditions that commonly affected men, especially those who enjoy drinking or happy hours, such as chronic liver diseases, liver cancer, benign prostate enlargement, and lastly, snoring or sleep apnea. Throughout the session, you can submit a question to our speaker through the Q&A box in Zoom, and our speakers will address them at the end during the live Q&A portion for you. Please remember that this is the Q&A box and not the chat box. The speakers will not be able to see the question or answer them if you submit it in the chat box. So, without much further ado, let's welcome our first speaker, Dr. Terence Tan, Associate Consultant of HGH, Department of Gastroenterology and Hepatology, who will share with us on chronic liver disease and liver cirrhosis. Dr. Tan, over to you, please.
Okay, good afternoon, everyone. So I'm Dr. Terence Tan. Again, as Samuel has kindly introduced, I'm from the Department of Gastroenterology and Hepatology. But more simply, it's basically we're the gut and liver doctors. And of course, I'm from SGH. So we'll be going through a rather broad topic today of chronic liver disease and liver cirrhosis. Each of these components itself can span a very long time in terms of duration. So I'll try my best to be succinct and summarize as best I can. So why is it important? Why is chronic liver disease and liver cirrhosis important? So chronic liver disease of any kind basically leads to liver cirrhosis or scarring of the liver and liver cancer as part of its natural history, or basically what happens if that chronic liver disease is not treated. So both are significant contributors to years of life lost, and this was assessed by the Singapore Burden of Disease Survey, where they ranked 20th and 8th respectively. Why is it important to men? Well, practically 64% of the patients with liver cirrhosis that we see in SGH are male, so it's almost a 2-to-1 ratio as compared to the ladies. And liver cancer is the 5th most common cancer in Singapore males, which my colleague Dr. Koh Yesin will be speaking about later. So maybe we start at the end to know why chronic liver disease is important in the first place. So liver cirrhosis is basically the final stage of all kinds of chronic liver diseases. This results when healthy liver tissue is replaced by scar tissue. And this is because the liver undergoes repeated cycles of cell damage and repair, and over many years, this eventually leads to a scarred liver or cirrhotic liver, as you can see in the pictures. This is unfortunately an irreversible change, which means that our focus should really be catching patients with chronic liver disease and making sure they do not progress to liver cirrhosis. When you do have liver cirrhosis, it is not the end either, because you can either be compensated, which means that the liver is still functioning well despite the exterior scarring, or it can be decompensated where the liver itself is basically on the brink of failure. So why liver cirrhosis is important? Basically, there are multiple complications that can happen after you get liver cirrhosis, and you can see some of the pictures here. The first is accumulation of fluid in the abdomen. You can see that in the picture in the lower right. This gentleman is not fat, despite his abdomen being very distended. You can see from the mirror that he's actually almost skin and bones, and his distended abdomen is completely from water or fluid accumulation and not as a result of fat. Subsequently, patients can also get yellowing of the eyes and skin. This is known in medical terminology as jaundice, as you can see from the upper right picture. This basically is a result of the liver being unable to clear bilirubin from the body effectively. This is what the yellow pigment that causes jaundice. Thirdly, there can be development of abnormal blood vessels leading to gastrointestinal bleeding. This usually manifests very dramatically as vomiting of blood or passage of black-colored charcoal-like stools. The picture that you see in the upper left is a picture taken during a scope where this scope was done to try to find the source of bleeding and to stop the bleeding. And here you can see the abnormal blood vessels spurting out blood. If left untreated, this is a life-threatening complication of liver cirrhosis. And lastly, but not least, there is definitely an increased risk of liver cancer. So common causes of chronic liver disease in Singapore, I've broken them down as per how often they occur. The first would be that of chronic hepatitis B. The second is that of chronic alcohol ingestion. The third is that of chronic hepatitis C. The fourth is non-alcoholic fatty liver disease, or fatty liver in short. And the last are autoimmune liver diseases like primary biliary cholangitis and autoimmune hepatitis. This slide is unfortunately full of medical jargon because that's how we describe the diseases, but we'll be breaking down each and every one of these diseases in the coming slides, so not to worry. So we'll start off first with chronic hepatitis B. And this is because this illness is the leading cause of chronic liver disease, liver cirrhosis, and liver cancer in Singapore. Hepatitis B is a DNA virus, and on the latest seroprevalence surveys, which is basically we took blood from healthy volunteers around Singapore, 3.6% of adults aged 18 to 69 were found to be carriers of hepatitis B, and more worryingly, a significant proportion were not on regular follow-up. Hepatitis B is important because it makes up more than 60% of our cases of liver cirrhosis that we see, as well as conferring a more than 100-fold risk of liver cancer simply just by having chronic hepatitis B. So how did 3.6% of the population get hepatitis B in the first place? Transmission of hepatitis B in Singapore is usually vertical. What this means in simple terms is that it is usually transmitted to the patient during childbirth, meaning that the patient's mother was usually hepatitis B infected and passed it to them as they were giving birth to the patient. So horizontal transmission is possible through sexual contact or blood-to-blood contact. However, this is more uncommon in Singapore. Most of our patients actually got it during when they were born. I just want to dispel a common myth about hepatitis B, that it is not foodborne and it cannot be transmitted via contaminated food, which means that patients with hepatitis B should not worry about sharing food with their friends and family. Notably, all children born after 1985 are vaccinated against hepatitis B under the National Childhood Immunization Program. And thus, because there's a 90% success rate in prevention or transmission of hepatitis B to these children, we expect the rates of chronic hepatitis B to decline in the future. However, in the next 5 to 10 years, it still remains the leading cause of liver cirrhosis and liver disease, and hence it's something important that we have to know about. So when it comes to chronic hepatitis B, it's usually diagnosed via blood tests. This is how we figure out whether you are a hepatitis B carrier, as to whether there's any liver inflammation as a result of hepatitis B in the first place. So if you do have chronic hepatitis B, I would strongly encourage you to be on regular follow-up. The polyclinics are well equipped to handle hepatitis B patients with at least 6 to 12 monthly liver function tests. Those are blood tests, as well as ultrasound scans because of the risk of liver cancer that I mentioned earlier. If the case of hepatitis B is a bit more advanced, a bit more complicated, there are treatments available for hepatitis B. However, our current medical treatments, which is basically tablets, are not capable of curing the patient. However, it is very capable of bringing it under good control. So moving on to the next cause of chronic liver disease. Alcoholic liver disease is the second most common cause of liver cirrhosis from our 2015 survey, and basically it accounted for 11.2% of liver cirrhosis patients that we saw. This results after many years of heavy alcohol ingestion. So just one binge on a special occasion isn't going to get you alcoholic liver disease, but rather the patients that we see have been habitually drinking much more than the healthy limit of alcohol, and this is over a prolonged period of time. Usually we can tell that they have liver inflammation by looking at their liver blood tests, which will usually be high. And if you have alcoholic liver disease, my message is that the best form of treatment is abstinence from alcohol. The main reason is alcohol is directly hepatotoxic, meaning that it's directly toxic to the liver. And thus, if you cut down or hopefully manage to stop your alcohol ingestion altogether, then there's some possibility that the liver damage can actually slowly get better as your body tries to repair the damage done by the alcohol. The third cause of chronic liver disease that I moved up a little bit would be that of non-alcoholic fatty liver disease. This picture shows the difference between a healthy liver and an unhealthy liver. And basically in non-alcoholic fatty liver disease, you can see that the unhealthy liver is full of fat cells. That's what the clear bubbles are. These are all bubbles of fat, and they're accumulating within the liver itself that we can see on a microscopic level. Unfortunately, fatty liver disease is very strongly associated with obesity and diabetes. And even though we do not have a population level survey on how many people with fatty liver disease there are in Singapore, we actually had this initiative where we reached out to everyone at the Public Health Forum who was interested in getting a free liver scan as well as liver test. And we found that 40% of participants from this health forum alone were found to have fatty liver disease. This is actually in common with data from other developed countries such as the US and the UK, where about at least one third of the population, if not up to 40% of the population, have some form of fatty liver disease. Because obesity and diabetes are going up in importance as well as in prevalence, which means that it's becoming more common in the population, non-alcoholic fatty liver disease is projected to be the leading cause of chronic liver disease and cirrhosis in the future, meaning that in about 10 or 15 years' time, we do expect this chronic liver disease to actually overtake hepatitis B as the leading cause, the number one cause of liver cirrhosis. So how do you find out whether you have fatty liver disease? It's usually detected via blood tests, which is how we find out whether you have elevated liver blood tests suggestive of liver inflammation. And sometimes we find out via an ultrasound scan of the liver, which shows fatty liver. The mainstay of treatment for non-alcoholic fatty liver disease at this point in time is still weight loss. There's no getting around it, unfortunately. Whether it be a combination of dietary modifications, increased exercise activity, or perhaps in combination with bariatric procedures, ultimately weight loss has been shown to reduce the severity of fatty liver disease, and in some cases even reverse the scarring that we can see on the liver biopsy. Medications for non-alcoholic fatty liver disease are unfortunately not yet approved in any developed country to date. They are still undergoing clinical trials, of which SGH has taken part in a few, but it is not quite yet ready for widespread deployment. We are expecting these medications for non-alcoholic fatty liver disease to come on board in about 2 or 3 years' time. But as of now, the mainstay of treatment for non-alcoholic fatty liver disease is primarily weight loss. The next cause of chronic liver disease would be that of chronic hepatitis C. This is fairly not so common in Singapore. Roughly about 0.1% of the population have this, and it accounted for 6.9% of patients with liver cirrhosis that we saw in our hospital. It is a blood-borne viral illness like hepatitis B. However, transmission is a bit different for hepatitis C. Usually, our patients with hepatitis C, they basically get it through either sexual contact, or there's a very specific population that we're looking at which has high rates of hepatitis C, which would be those people who use injection drugs. And when they share needles, there's a very high risk of passing hepatitis C to each other. Diagnosis of chronic hepatitis C is via blood tests, and if left untreated, again, like all chronic liver diseases, it does lead to liver cirrhosis over a 10 to 15 year period. However, medical science has actually enabled the easy eradication of hepatitis C with these direct-acting antiviral medications. These were developed over the last 3 to 5 years, and since then, we've had very good results with these medications for patients with chronic hepatitis C. A 3-month course of these medications, which are all oral, meaning there are no injections involved, very minimal side effects. It has a more than 95% success rate in curing the infection. And it is hoped that over the next few years, we will be able to more or less wipe out chronic hepatitis C as a cause of chronic liver disease from Singapore itself. Moving on to the last cause of chronic liver disease that we commonly see, autoimmune liver diseases basically are liver diseases where the immune system, for an unknown reason, instead of attacking viruses and bacteria and foreign particles, they actually start to get reprogrammed and they attack the liver by mistake, our own liver by mistake. These two conditions basically account for 5% of liver cirrhosis seen in our hospital. One is primary biliary cholangitis and the other one is autoimmune hepatitis. So for both autoimmune liver diseases, we primarily diagnose them via blood tests, where we look out for, of course, elevated liver blood tests suggestive of liver inflammation, as well as the presence of autoantibodies, where the body makes antibodies that are targeted at our own cells. This is a very clear sign that the body is attacking itself, and this is usually how we diagnose autoimmune liver diseases. Treatment for these conditions are usually via oral medications, and even though they require long-term medications, most of our patients with these liver diseases have good control of their condition with these oral medications. They, however, need to be followed up long-term with a liver physician. Okay, so that's more or less the end of my talk. We've covered quite a lot of conditions, as summarized as best as I can. And the take-home messages that I would like to stress to everyone is that chronic liver disease, liver cirrhosis, and liver cancer are important causes of illness in Singapore. These are easily screened for with blood tests. So if you go for a yearly checkup with your company doctor, or if you go for a yearly screening with your polyclinic, do make sure that they add in the liver blood test. If your health screening package has the option for an ultrasound scan, you can probably throw that in as well, just to look out for whether you might have fatty liver. Effective treatments are available for all of these chronic liver diseases to prevent irreversible progression to liver cirrhosis. So the aim for us is to pick patients up as early as we can so that we can intervene as early as we can and prevent further development to liver cirrhosis. And with that, I've come to the end of my talk. Thank you everyone for your attention, and I'll be happy to take questions later.
Thank you very much, Dr. Tan, for the very informative sharing on chronic liver diseases and liver cirrhosis. Again, if you have any questions for Dr. Tan, please submit it through the Q&A box, and Dr. Tan, as well as all the speakers, will address them for you at the live Q&A portion later. Next, let's move on to a related topic of non-alcoholic fatty liver disease and liver cancer, presented by Dr. Koh Ye-sin, consultant from Department of Hepatopancreatobiliary and Transplant Surgery of SGH. Dr. Koh, the floor is yours now.
Yeah, hi everyone. My name is Ye-sin, and I'm a consultant in the Department of HPB and Transplant Surgery. So, are we on the first slide? Yes, Samuel, can you help me with the slides? Yeah. So I'm a surgeon, and so I just present a bit on the perspective on liver surgery for non-alcoholic fatty liver disease associated hepatocellular carcinoma. As Terence stated in his presentation previously, this has become an increasingly important cause of liver cancer in our population, and I'm here to expound a little bit more on that for the surgical treatment of liver cancer, and also to debunk some myths. The next slide, please. So basically, I'm sharing with you our department data on liver surgery for liver cancer due to fatty liver disease. Next slide, please. Next slide, please. So the background is that non-alcoholic fatty liver disease is a spectrum. I mean, there's a spectrum from simple fattiness called simple steatosis to steatohepatitis, that means a bit of inflammation due to the fatty liver, and liver hardening, as Terence stated previously, and even liver cancer, and this can occur in the absence of apparent cirrhosis. And I think this is one of the key points that's important to take note of. Next slide. Yeah, so there are many ways of diagnosis. One of the most common ways that we diagnose non-alcoholic fatty liver disease is by imaging, and I'm sure many of you have undergone some form of health screening with ultrasound liver that tell you have some form of fatty liver. This is usually based on imaging extrapolation of what they see. Well, the gold standard of this is the reality is that it's by biopsy. Based on the pictures just now, you have noted that it is a spectrum, and the extent of this fatty liver will need to be evaluated more closely by biopsy. So the majority of all fatty livers are actually mild, but if your hepatologist recommends a biopsy, please don't be alarmed, because there might be a real need in your situation to classify the extent of the steatosis. Next slide. Well, the most common age is around 40 to 50s. There's mixed data on sexual preponderance. And like what Terence mentioned just now, these are the key reasons for association with so-called fatty liver disease, like metabolic syndrome, obesity, hypertension, dyslipidemia, and even diabetes. Next slide. Well, this is a graphical representation of what's happening in the world. Both in the West and the East, we see common things occurring. That means non-alcoholic fatty liver disease increasing in prevalence, and can continue and will continue to account for the majority of liver cancers in the future. The most sharp arrow represents USA, leading the world in terms of obesity as well, and then the Asian countries following the same trend, but not such a sharp rise, of course. Next slide, please. Well, some of the existing literature do state that so-called fatty liver-associated liver cancers are known to have a poorer survival and higher complication rate because of surgery, and high percentage of death after the operation. But the lack of long-term data and the lack of region-specific data makes this a little bit difficult to generalize and interpret. So I will share with you the results of our department study later. Next slide, please. The next slide, please. Yeah. So how does this non-alcoholic fatty liver disease occur? And basically, it's a derangement in the metabolism, resulting in increased what we call fatty breakdown, triglyceride synthesis. That means a form of fat, and the liver takes up this fat and accumulates it. When it accumulates it, sometimes there's this oxidative stress that happens, causing inflammation, and this resulting inflammation and a continued duration of that results in a long-term liver damage. Next slide, please. The next slide, please. Well, this is another graphical pictorial representation of the issue, and certainly there's potentially some interaction with what we call the gut microbiome. That means all the bacteria living in the gut. And there is growing interest in that region, although definite data is very difficult to draw from this mixed bag. It remains a field to be subject to future research. Next slide, please. Basically, I want to share with everyone what our findings, the primary findings of our study is, and what is the actual results of patients who have undergone liver surgery for liver cancer due to fatty liver disease. Next slide, please. I'll let you appreciate that this is what is seen from a resected liver specimen. As you can see the picture on the left, the part that's roundish is the cancer, and the part that is more shiny is the normal liver, but you can see a tan of yellow color around the liver. This usually indicates some form of fattiness. The picture on the right side shows the liver cancer on the background of cirrhotic liver. That means this liver has been chronically damaged by the inflammation. Next slide, please. Well, we look at all our data based on the international network. Next slide. And as you can see from the pictures, again, this is defined by what is seen by histology, the extent of what we see under the microscope. That means the extent of what we call the fattiness of the liver and the inflammation that occurs. The next slide, please. So the statistical outcomes, we follow our patients for a certain duration of time. There are certain definitions that need to be seen. The next slide, please. And our statistical methods are sound. And importantly, is the important factors are being modulated. Next slide, please. Yeah, so you can see the patient pool accounts for almost 1,000 patients within all our resection candidates. The next slide. Our data do strongly suggest that the factors of what we call age, high blood pressure, high cholesterol, heart disease, and all these chronic health problems are associated more commonly with fatty liver. But interestingly, the tumor size for those with fatty liver are actually smaller, and the percentage of people with cirrhotic livers who undergo surgery for HCC are actually smaller. Next slide, please. And some of the other newer markers, like your white blood cell count and your platelet level, are actually more pronounced in the fatty liver disease. Next slide. And interestingly, to note that the extent of severe cirrhosis denoted by the fibrosis level is actually not the predominant percentage in all patients with fatty liver disease associated liver cancer. Next slide, please. We also looked at some of the definitions based on some international classifications of liver failure. Next slide, please. Now, this is one of the most important slides, is that the long-term outcome for fatty liver disease associated liver cancer, if you can look at the OS, is 70%, which is better than the non-fatty liver than the non-fatty liver cancers. Next slide, please. And you can see the two curves with the red curve showing a better survival throughout all ages for fatty liver disease associated liver cancers. Next slide, please. And again, our data strongly suggests all the above that I mentioned. Next slide, please. Next slide, please. So, well, some of the key take-home messages is that Singapore General Hospital is the largest single-center study in the world examining these outcomes. In the historical series, although they are stated to be larger, more multifocal, and more likely to require major liver surgery, we found that this is actually not true. In our series, they are smaller sized, they are less likely to require major resection, that means less sacrifice of your liver. And more importantly, the next slide. In our hands, the patients live longer, have less recurrence. Although there is some form of liver failure, this is an inherent problem in already compromised liver from the fattiness. And although there are some lung and heart complications, these are actually what we call the baseline rate in patients who are actually bigger in size. Importantly, our 90-day mortality is very, very low, and it's considered one of the best in the world. Next slide, please. Yeah, so the key take home is that in patients with non-alcoholic fatty liver disease who have liver cancer, surgery should be considered, and that the historical data that suggests poorer survival is actually not true. Yeah, okay, thank you. That's the end of my presentation.
Thank you very much, Dr. Koh. I think we have a very good understanding on the difference between non-alcoholic fatty liver disease and versus the fatty liver disease for liver cancer. For the audience, if you have any question on the surgical methods or the difference in outcome from these conditions, please submit it to the Q&A box, and Dr. Koh will address for you at the end of the sessions. Now, let's welcome Dr. Edwin Jonathan Aslin, consultant at HCH Department of Urology, who will talk about his specialty, benign prostate enlargement. Dr. Edwin, please.
Okay, hi, good afternoon, good evening, everyone. My name is Edwin. I'm a urologist, so that means I deal with the surgery of the urinary tract, in particular the prostate, kidneys, bladder, and so on and so forth. Let me just share my screen. Okay, can everyone see my slide? Samuel, can you see my slide?
Yes, sir.
Okay, all right. So that's a kickstart. So I'll take me about 20 minutes for this. Hold on a second. Okay. All right. So I'm going to talk about BPH or benign prostate hyperplasia. This is a common condition affecting older men. In particular, how do we treat it? So I'm going to go through some basic concepts, how to treat BPH, and surgical options that are available to treat this condition. Okay, so BPH stands for benign prostate hyperplasia. This is an age-related, non-cancerous enlargement of the prostate. The prostate is just right here. It's a gland that sits just below the bladder. It is also a component of the outlet of the bladder. So when there is an enlargement of the prostate, you can get a distortion of the bladder outlet, and this can then cause urinary obstruction. It is a common problem. Some studies have shown that it affects 50% of men by the time they are 50 years old. But of course, not all these men will have symptoms that are troublesome enough for them to see a doctor. Only a small proportion will see a doctor for the urinary problems at this age. The typical symptoms, I would categorize them into three. One is the flow symptoms. These are things like slow flow. When you pass urine, you have to start-stop. Take a while to start the urine at first, and at the end, you can get some dribbling, some dripping at the end. You can also have bladder symptoms, such as frequency, urination, keep going to the toilet very often, urgency, that is to say, before your bladder is very full, you have a strong urge to go to the toilet before it's very full. You can also have nocturia, which is the nighttime urination. We classify anything more than 2 times a night is significant. But however, these symptoms are not different from those of prostate cancer. So it is important for us to, first of all, make sure that there is no prostate cancer. So how do we evaluate someone that we think who might have BPH? 4 basic tests. One is the uroflow. This is a test of how fast your urine flow is. When you see us in the clinic, we'll get you to pass urine into a machine, and this will then check how fast your flow is and what is the pattern like. You will also receive a digital rectal examination where we examine the prostate from the back passage to feel for any abnormalities, any suggestions that there could be prostate cancer. We will also do a PSA. We will go through this later. This is a tumor marker for prostate cancer. And finally, we will also assess your prostate with an ultrasound scan, looking at the shape, the size of it, and how it impacts on your urinary flow. So, basic concepts again, the functions of the bladder. So the bladder has 2 main functions. It acts as a reservoir when for the storage of urine. And during this phase, it is relaxed. It can contain up to 500 cc. And after which, by the time it is full, someone will feel that you will have the urgency to pass urine. And then at this time, the bladder then acts as a pump by emptying out urine. The prostate has 2 functions. One is a sexual function. It is a sexual gland. It makes a component of your semen. It is also a part of your bladder outlet. So that is to say, it maintains continence, which means that it prevents urinary leakage in the normal situation. So PSA, what is PSA? This is a prostate-specific antigen. It's a tumor marker for prostate cancer. It is an enzyme in the prostate that is made by both normal prostate cells and also cancer cells. So it is higher in prostate cancer, but it can also be high in other conditions. For example, for someone with a very large prostate, but benign, there's no cancer inside, you can get a high reading just by virtue of the volume. You can get it, the level can be raised also in conditions such as inflammation, infection, and of course in prostate cancer. There is no real cutoff, but internationally we accept 4 as anything below 4 as normal. So if you have a prostate cancer, PSA marker on screening that is more than 4, you should have further evaluation to rule out prostate cancer. Typically, we would offer a prostate MRI nowadays as a first line, and if the MRI shows there's suspicious spots in your prostate, we would then proceed to offer a biopsy to rule out prostate cancer. So the bladder outlet, as we mentioned earlier on, in the normal anatomy, the bladder neck here is open, it is funnel in shape. The prostate channel is also open. This is normal. But in a BPH, in an enlarged prostate, you can see it is grossly abnormal here. The bladder neck is shut, it is distorted. Why? Because the prostate is enlarged, causing shape distortion, and it is also compressing on the prostate channel. The channel here is closed and distorted. And therefore, when you have enlarged prostate, you can have problems with your urinary flow. So the symptoms caused by BPH are as a result of the changes in the balance between the bladder pressure and the outlet pressure. But for a bladder that is blocked for a long time, you may ask me, so do we need to treat it? Is it safe to just leave it alone? The answer, it depends. It depends on how bad the blockage is. In high-grade obstruction or severe blockage, you can get changes to your bladder, which eventually, in the end, may become irreversible. In the first stage, the bladder muscle thickens up because, as you can imagine, there is a blockage here. In order to push the urine out, your bladder has to kind of thicken up the muscle, so you get muscle thickening. In stage 2, the bladder overcompensate in order to fight against the resistance. The bladder muscle thickens and you end up with a high pressure urination. You can still pass urine. Some patients may still feel that the urine flow is normal, but this is generated under high pressure. And you start to get abnormal bladder contractions as well in this stage. In the final stage, what we call the decompensated bladder, where the bladder has been subjected to high resistance at the prostate level for a long time. It kind of give up, if you can put it that way. Then you get loss of bladder strength. You can get problems with incomplete emptying. To demonstrate this, if let's say I were to put a scope inside the bladder to have a look, on the top, this is a normal looking bladder. You can see the skin of the bladder is very smooth. You can see some blood vessels there as well. This is normal. But at the bottom, you can see the bladder is obviously abnormal. It's very rough. The muscle is very thickened, but this is not normal thickening of the bladder muscle. And you can see that the blood vessels are not normal anymore. It is kind of light in color. It's quite pale, the skin of the bladder. So that is because the blood flow to the bladder is also affected at this stage because of the high pressure. So this, when someone has reached this stage, a lot of the problems related to the bladder function cannot be reversed anymore. But from this stage 1 or stage 0 to stage 3, it can be avoided with treatments either by medications or surgery. So when to treat BPH? It depends. Just to put it in a nutshell, in a very simplistic way, I would ask the patients, how bad are your symptoms? Is it mild, moderate to severe? Do you have high-grade obstruction? And do you have complications from BPH? How do we determine high-grade obstruction? So we do it by 2 things. One is a very slow flow on the uroflow test. The second is you have a high residual urine. That means that after you pass urine, you always have a remnant or leftover urine in the bladder that is not cleared properly. If the volume is high, then we would say that the degree of blockage or obstruction is high and you would benefit from treatment. Complications of severe BPH would include things like retention of urine. You cannot pass urine at all. Repeated urinary tract infections, bladder stones, persistent blood in the urine. This is a red flag. If you see blood in the urine, you should see a urologist, because it may not just be the BPH, it may be other things like bladder tumors and things like that. And when you get such a severe blockage that the kidney function starts to get affected also, this is considered complicated as well. And you will need treatment. So in general, in a very simplistic way, I would ask the patients, if, let's say, the patient has very mild symptoms, but no high-grade obstructions, no complications from BPH, then perhaps just a simple lifestyle changes could suffice. For example, by cutting down on caffeine, limiting your, regulating your fluids intake so that you don't have to go to the toilet very often at work or at night. Some patients are on the prostate supplements or herbal remedies such as, saw palmetto, prostacan. While research have not shown that this is helpful, but I believe it can help because many patients tell me that by taking the supplements, they actually feel a real improvement in their symptoms. So if you ask me, I would say go ahead and then take those supplements. I think they probably actually do some good. It's just that we haven't managed to prove it yet with the research. And some patients, even though the symptoms are mild, they would rather to have to be able to pass urine even better than I would offer them medications. So the medical treatments for BPH, there are two main ones. The first one is alpha block, what we call a group of medications that we call alpha blockers. It works by relaxing the muscle at the bladder neck over here, and also the prostate smooth muscle. By relaxing the muscle, then you would open up the bladder outlet, and thereby you can improve the urinary flow. Some of the common side effects with this group of medications are giddiness, because it can affect your blood pressure. It can cause your blood pressure to drop a little bit. It can cause abnormal ejaculations as well. Some examples of this class of medications, some of you may be on it: terazosin, alfuzosin, and tamsulosin. The next group is what we call the 5-alpha reductase inhibitor. So how does this one work? It improves the flow over time. It works very slowly. It improves the urine flow over time by shrinking the prostate size. It is a kind of a mini hormone tablet that acts on the prostate. But as a result, as a side effects, it can cause erectile dysfunction and a lack of energy because, as I mentioned, this is a kind of a mini hormonal pill in a way. Okay. An example are two medications, finasteride or dutasteride. Some of you may already be taking finasteride. The brand name is usually is Proscar. Some of you may be taking it for hair loss, for male hair loss, in this, and a lower dose. Some patients, we also prescribe them tadalafil. The brand name is Cialis. This is a cousin compound of Viagra. As you know, this group of medications, we use it for men with erectile dysfunction. But for this tadalafil, at a low dose taken daily, it has been shown to help with the urinary flow. So we use it for men who also have existing erectile dysfunction, although we don't use it as a first line because the effect is inferior to the first two mainstay medications. So for those patients with mild to moderate symptoms, and on evaluation they are found to have high-grade obstructions, then I would advise to start on medications. And if medications don't work, or you do not want to be on medications because of side effects, or you do not want to be on anything long term, then I would offer surgery. There are two types of surgery. The standard surgery is TURP, is the cutting of the prostate tissue to open up the channel. But now we also have a minimally invasive treatment options. We have two established ones, which are UroLift and Rizum. We'll go through that shortly. But the moment you have complications for BPH, like we mentioned earlier, things like recurrent infections, bladder stones, and such, then forget about medications or the minimally invasive option. You have to go for TURP to prevent your bladder from reaching a state of decompensation where the changes cannot be reversed anymore. So when should you go for BPH surgery? When you have complications of severe BPH, when medications are not working, or it's your choice. But there are many, many different types of surgical treatment options available now. If you read online, or if you go to in the newspaper or online, which one is for me? TURP remains the gold standard. This is transurethral resection of the prostate. This has been around for a long time. This surgery is the gold standard. It results in the best improvements in flow and urinary symptoms. And also it reduces your residual urine by the largest margin, and it is the longest lasting treatment, up to 22 years in some studies. How we do it? Under anesthesia, usually half body, the patient is still awake. but under half body anesthesia, we put a rigid scope through the penis, past the prostate into the bladder, and then from inside out, we shave the prostate so that the channel is open. You can see on the scope view in this patient, or in this diagram, you can see the two halves of the prostate causing a blockage. You cannot see the entrance to the bladder. With the cutting device, we will remove the obstructing parts, the parts that is blocking the bladder. And then before and after, you can see a clear opening here. And you can just imagine that after this treatment, the flow is very good. So the essence of this surgery is to convert a blocked channel into an open channel by removing the obstructing tissue. The effect is remarkable. You can see the urine flow tracing below. This is the obstructed pattern. Slow, takes a long time for the patient to clear the urine. And after surgery, the flow is very fast. You can see the obvious change in the pattern. The maximum flow rate has improved by 3 times from 7.4 mils per second to 24 mils per second. But what the patient actually experienced the most is the reduction in the time it takes for you to complete your void. Before surgery, this patient takes 78 seconds to pass out about 230 cc. And after surgery, you cut down the voiding time by very much. Now it's only 14 seconds. But this surgery is also associated with its own set of complications such as bleeding, recurrent infection, urinary retention, and very rarely salt imbalances. The long-term side effects, the most significant of which are sexual in nature, such as abnormal ejaculations and erectile dysfunctions. And you can also get other long-term problems also, although they are less common. You may have heard about TUERP, HOLAP, TULAP. These are all laser techniques. Green light, TUVAP. These are all just variations of a TURP. The essence of the surgery is the same. You want to cut the prostate to create an open channel, but just by different means. In this, using different type of energy, using laser, using plasma, whatever the surgeon decides. Of course, the difference is there is some difference in the recovery experience and in the cost as well, cost of the surgery. Minimally invasive surgery, 2 types, 2 established ones, Urolift and Resume. There are many other forms of minimally invasive treatment options such as prostatic artery embolization, ProLift, but all the rest of the options are still considered technologies under investigation. They are not the established treatment option yet, but Urolift and Resume are established already. The advantages of minimally invasive treatment options are that you can avoid the complications associated with TURP. You can preserve the sexual functions, especially for those men who value the sexual functions above all else. But of course, the disadvantage is this group of treatment is relatively new. The longest one with evidence is Urolift at 7 years. Anything more than 10 years, we don't know what's the outcome. I believe that they don't last as long as TURP, but they are minimally invasive. The treatment fails at some point in time. You can have it done again, or eventually go for TURP. It is still possible. So in Urolift, the treatment name is called prostatic urethral lift, where how we do this procedure is we insert the scope into the prostate. We fire little implants into the prostate. We push away the middle of the prostate apart so that you have an open channel like that. This is from a case that I did. You can see that the prostate is causing a blockage here. And after the procedure, you can see the parts that are blocking are being pulled away by the implants. You can't see the implants here, but it is there. So in that way, you create an open channel to the bladder. The benefits is that you get preservation of sexual functions, 0 rates of erectile dysfunction and ejaculatory dysfunction. But the improvement in the urine flows, urinary symptoms, and the quality of life are modest. It is not as good as TURP. The effects are durable through 7 years. The other option is Resume, which is a water vapor treatment. It's a kind of a steam injection into the prostate, delivered through a device, inserted into the prostate. Then we inject steam into the obstructing part of the prostate. And then because you steam it, the tissues kind of get damaged, and over time, your body will reabsorb the tissue, and when the tissue is reabsorbed, you then get an open channel. There are no foreign bodies involved in this process. But the time it takes to resorb the tissue can be more than a month before, more than a month. So therefore, it takes the patient more than a month before you start to show any improvement in your symptoms after treatment. Again, preservation in sexual functions are its benefits. Also, modest improvements in the urinary flows and symptoms. There is a prostate volume reduction by about a third at 6 months. The effects are durable through 5 years. Any longer, we do not know yet. We do not have data for those. These 2 treatment options are available at SGH. So the choice of surgery then, it is kind of depends on what you want to achieve. What is your aim of surgery? For example, if your main aim is you want a lower urinary tract symptoms relief, your main aim, you just want to have a good flow, you don't care about anything else is not important for you, then TURP probably is the best option for you. It is the most cost effective, longest lasting, and results in the best flow. But however, if you think that you want to avoid some of the complications with TURP, you want a better recovery experience, then you can consider the other variation of TURP, such as the laser techniques. They have less bleeding, faster recovery, and less pain in certain reports. Of course, they are also more expensive. If you are someone who wants to preserve your sexual function, your ejaculation, your erectile function, your continence, these are the most important items for you, then you might want to consider something minimally invasive, such as Urolift or Resume. And there are different treatment options. Ultimately, it depends on how bad your symptoms are and what is your choice of treatment. So, as take-home message, BPH is very common in men above 50 years old, although not all men will present at this age. Urinary symptoms are caused by the outlet obstruction. And as part of the workup, we will do a PSA check, and if this is found to be high, we will need to rule out the presence of the possibility of prostate cancer. The choice of treatment then depends whether how severe the symptoms are, how bad is the obstruction, and whether whether you have complications from BPH. For those men with mild to moderate BPH symptoms who want more choices, you may consider minimally invasive treatment options. And these are all available at SGH. You can always reach out to us if you want to discuss some of this. Thank you. I think that's the end of my talk. I'm happy to take questions at the end.
Thank you very much, Dr. Edwin, for this insightful sharing on benign prostate enlargement and what can be done for it. For the audience, again, if you have questions for Dr. Edwin, please feel free to submit to the Q&A box, and Dr. Edwin, as well as other speakers, will answer them for you later. I think we come to the last topic of the day. I think we cover liver from drinking. We cover urinations. Now it's about snoring. I think that's happened to many of us after we drink too much. This topic will be covered by Dr. Sean Low, consultant from Department of ENT, Head and Neck Surgery of SGH. Dr. Sean is here with us today. However, he also prepared a recording of the lecture, which I'm going to play for you now.
Good afternoon, everyone, and thank you for joining me for this talk on snoring and obstructive sleep apnea. A brief overview of today's talk. First, I'll talk about what OSA is, why I think it's relevant, how we can recognize OSA, and tell you about some of the treatments available right now. So before I talk about OSA, maybe I should talk about what happens every night as we sleep. As we fall asleep every night, we enter stage 1 sleep, and then as we go deeper into sleep, we go into stage 2, stage 3, and then REM sleep. REM sleep is a stage of sleep where dreams occur. So every night we go through all these stages several times. Each cycle lasts typically between about 90 to 120 minutes. Stage 1 and stage 2 sleep are considered light sleep, whereas stage 3 and REM sleep are considered deep sleep. So for one to feel refreshed the next day, one needs to have adequate amounts of stage 3 and REM sleep. If for some reason the sleep is disrupted and you hover in stage 1 and stage 2 sleep, then even if you have sufficient quantity of sleep, because the quality is compromised, you wake up tired the next day. So what exactly is OSA? Simply put, it is repeated episodes of collapse of the upper airway at night that results in obstruction of breathing during sleep. So if you look at a normal patient, the upper airway from the nose and mouth to the voice box is unobstructed and airflow is smooth. In sleep apnea patients, the upper airway gets blocked up multiple times at night. And this results in breathing disruptions that are associated with drops in blood oxygen levels that cause arousals from sleep. So these arousals from sleep are actually commonly not full arousals, meaning to say that the patients are not aware of this blockage and they don't wake up. Rather, these are micro arousals whereby patients transition from deeper sleep into lighter sleep. And as you remember in my earlier slide, if you end up with a larger proportion of light sleep, you end up waking up feeling more tired. So why is it relevant? Well, I think OSA is relevant because it is very common, with more recent studies showing that up to 17 to 50% of adults worldwide have OSA. In Singapore, it has been shown that the prevalence of moderate to severe OSA is about 30%. So, if you think about it, 1/3 of the people in attendance today could very well have OSA. And I think what is more important is that this study showed that a large proportion of the patients were actually not aware that they had this problem. And why is it important that we know, why is it important to diagnose OSA? Because OSA is related to increased cardiovascular risk. And this has been shown by many studies. Just take, for example, this study that looked at 1,651 men. They showed that men with OSA had a 3.5 times increased risk of dying from a heart attack. If you look at non-fatal cardiac events, the risk was about 4.7 times more. And how this happens is that OSA, like I mentioned earlier, causes the upper airway blockages causes intermittent drops in the blood oxygen levels and recurring arousals from sleep. Taken together, this results in activation of the sympathetic system or the fight or flight system that results in high blood pressure at night and increased damage to blood vessel lining. The drops in oxygen level also causes stress and inflammation that directly damages the blood vessels. Sleep apnea and the link to high blood pressure is also very well known. Many large cohort studies that look at a group of patients over a long period of time have shown that patients with OSA have a 1.4 to 3 times increased risk of high blood pressure. There have also been other studies that have shown that once these patients with OSA have their OSA treated with effectively either with CPAP or surgery, their blood pressures actually drop. OSA is also a common cause of nocturia or frequent urination at night. Of course, if you are in the audience today and you are experiencing nocturia, I would suggest that the first port of call, or rather the first doctor you consult, will be your urologist. But sometimes, when the urologist evaluate your urinary tract and find that they can't find a cause for your symptoms of frequent urination at night, they may then refer you on to an ENT doctor to do a sleep study to see whether OSA is a contributing factor. And the reason for this is that in OSA, when there's blockage of the upper airway, one has to generate more negative force to try to draw air in past the blockage. And this increased negative intrathoracic pressure results in increased filling of the heart with blood, causes stretch of the heart muscle, that results in increased production of this hormone called the atrial natriuretic peptide, which then acts on the kidney to produce more urine. Studies have shown that in OSA patients, once their OSA is treated, the frequency of passing urine at night, as well as the urine volume at night, actually reduces. Apart from the issues I talked about earlier, OSA has also been linked to heart failure, cardiac arrhythmias, or rather irregular heartbeats that occur at night, stroke, and high increased eye pressure called glaucoma. So how does one recognize OSA? Let's start by looking at some of the risk factors of OSA. Age is definitely a risk factor. Common complaint from patients is that, I've been snoring since I was a teenager, but only recently that my wife noticed that I choke, only recently that I start feeling tired in the day. The reason for this is that the upper airway is a muscular tube. It is lined by muscle, on all sides. And as you get older, the elasticity of this muscle gets reduced, and the collapsibility increases. So it tends to manifest later with age. OSA is also predominantly a male disease, and the reason for this is thought to be because of the female hormone progesterone. So progesterone, in the same way that it makes your girlfriend or your wife's skin more supple than yours, it also makes their upper airway muscles more supple, and because of the increased elasticity, their airways collapse less. But this prevalence is only seen in premenopausal women. After menopause, the prevalence of OSA in women actually kind of equalizes that of men after a while. Obesity is a main contributor to OSA because fat deposited in the neck around the jaw actually compresses on the upper airway at night, and this results in increased blockages of the airway. In our Asian population, abnormal craniofacial features such as a small jaw or receding jaw are actually main contributors. So, when you see a doctor, they will assess you to see which is the main contributing factor. Is it the jaw size, your skeletal profile, or is it obesity? Smoking increases the risk of sleep apnea because it increases mucus production and increased viscosity of the mucus in your upper airway. These more viscous secretions have increased surface tension that make your airway more liable to collapse. I'll talk a bit more on alcohol, seeing that today's theme is happy hour, and I'm sure many of us enjoy the occasional drink or two. Alcohol affects OSA directly because alcohol relaxes the upper airway dilator muscles, so the airway becomes more relaxed and more liable to collapse. After collapse, it also slows down your brain's response time and prolongs the time to awaken after the blockage occurs. So it worsens sleep apnea. Many people think that, I drink some alcohol to help me sleep better. And they have that mistaken belief because of the sedating effect of alcohol. So, you drink alcohol, yes, it's true that it reduces your time to fall asleep. But the problem with alcohol is that it gets metabolized and it is a short-acting sedative. So, as your body metabolizes the alcohol and your blood alcohol levels drop, there will be a rebound in the later half of the night whereby there's increased stimulation and increased arousals. So what typically happens is that patients will report that they have alcohol and they fall asleep quickly and they say they sleep very fast. But what happens is that as they go through the night, as the blood alcohol levels drop, they wake up at about 3-4 a.m. and they find it hard to go back to sleep again. Apart from the stimulatory effect of alcohol also reduces the proportion of REM sleep. So because there's less deep sleep, the patients actually wake up feeling more unrefreshed. So what are some of the symptoms of sleep apnea that you should be looking out for? Of course, one should pay attention. One should suspect that they have OSA if there's loud snoring, especially when it's associated with choking or gasping episodes. So what your wife or bed partner may report to you is that they hear you snoring, and then suddenly there's a period of quiet. And that period of quiet happens because there's a total obstruction and you stop breathing. And this is typically followed by a very loud snort when you suddenly gasp and resume your breathing. Patients also tend to report fragmented sleep and increased urination at night, like I mentioned earlier. Patients also tend to wake up in the morning with a morning headache because of poor sleep and oxygen deprivation at night. They wake up with a sore throat that occurs because of vibratory trauma to the throat. So if your throat vibrates the whole night because of the snoring, that causes trauma that contributes to a sore throat. Also because, when you're breathing against a blockage, the increased negative pressure that has to be generated to draw air in ends up drawing acid up from your stomach, and that acid that comes up causes the sore throat. Because of the arousals, patients will complain of other symptoms like unrefreshed sleep, excessive daytime tiredness, as well as mood disturbances in some. So when you go to your ENT doctor, we would assess your upper airway to see which areas contribute to your OSA. The upper airway is from the nose and mouth all the way to the voice box. So each of these areas from the nose and mouth to the voice box would be systematically assessed to see which areas contribute to the sleep apnea. So in the nose, this is a normal nose where there's a lot of space for air to flow. Compare this to a patient with allergic rhinitis, or what laymen like to call sinus, whereby there's a lot of swelling in the nose. You see that there's hardly any space. this patient has a deviation of the septum or a bent nose, such that air cannot flow well through the nose. Going a bit further back from the nose down to the back of the throat or the palate area, common contributors of obstruction include big tonsils. Sometimes the palate is too loose. So you compare this patient with a normal palate, whereby you can actually look down from behind and see a big wide airway. This OSA patient has a very narrow airway. Going beyond the throat, we also look at the back of the tongue. The tongue, obstruction at the back of the tongue can be caused by several factors, such as an excessively fat tongue. So, as you put on weight, fat gets deposited all over your body. The tongue is also a common area where fat gets deposited. So because the oral cavity or the mouth is a fixed space, as your tongue gets bigger, it tends to get pressed against the teeth harder. And so sometimes we tend to see this scalloping of the tongue that will indicate that the patient's tongue is large relative to the size of the mouth. Sometimes at the back of the tongue, there's also increased growth of lingual tonsils, which are tonsils at the back of the tongue that can narrow the airway. So comparing a normal patient with a very wide airway compared to an OSA patient where it's very narrow. But ultimately, the best way, or rather the only way to determine whether or not you have sleep apnea is to do a sleep study. Sleep studies, there are several forms that can be done, broadly divided into inpatient studies, whereby you sleep in the hospital and we observe your breathing, your heart rate, your oxygen levels to see whether or not you have sleep apnea, compared to a home study. So there are several reasons why your doctor may say that you are more suited to a home study or an inpatient study. Ultimately, the studies that are done in the hospital are considered the gold standard. They are the most accurate. And if you are a bit hesitant about coming to stay in the hospital, especially in the current climate, rest assured that, especially in our SingHealth Sleep Center, we have a single room, regardless of whatever class status you are paying for, single room with an attached toilet. And this is in the community hospital away from the sick patients. So yeah, don't let that be a reason why you want to defer seeking help. So once diagnosed with sleep apnea, what are some of the forms of treatment? The truth is, OSA is not just purely an anatomical disease whereby a surgeon can deal with it. Patients have to play their part. So patients have to evaluate their sleep hygiene together with the doctor to see what could be worsening it, like smoking or alcohol intake, for example. Weight management is important because, like I mentioned, fat around the neck and chin contributes to compression of the upper airway. And then, you and your doctor can then have a discussion to decide what the best form of treatment will be. It can be in the form of using a CPAP machine, whereby the sleep technicians will help you with it. It could be with the use of a dental appliance, or it could be through surgery. So coming to a sleep center like ours, over here we have the whole spectrum of treatment options for you. So the best form of treatment is CPAP. CPAP is a short form for continuous positive airway pressure. In essence, you wear a mask that is connected to a machine by the bedside. It pumps air in at a higher pressure that keeps the airway open. So I like to show this picture because I myself have OSA, and I do surgery for everyone, but I can tell you CPAP is the most effective, and I use CPAP every night. But the problem with CPAP is that not everyone can sleep with a machine, or rather with a mask strapped to their face. Studies have shown that the non-compliance rate can actually go up as high as 80%. So for patients that can't use CPAP, what are some of the alternatives that can be considered? An oral appliance is something that can also be considered. Essentially, it's something that you wear in your mouth at night. If you look at this picture, you wear it in your mouth at night. It positions your lower jaw forwards relative to your upper jaw. And because your lower jaw is positioned forward, your airway is bigger. But this is not without its problems in some patients as well, because it can cause a muscle ache at night. Imagine your jaw being pushed forward the whole night. It can cause salivation. It can cause movements of the teeth. And it's not suitable for those that are very obese or those with poor teeth, because it can result in teeth damage. So apart from conservative treatments, surgery can also be considered. Ultimately, surgery is done in sleep apnea patients for several reasons. It is either done to complement the use of CPAP or oral device. So for example, some patients have a very blocked nose or very large tonsils, such that using a device is very uncomfortable because the machine has to pump air in through a very narrow path. In some cases, we do surgery to allow them to use the machine more comfortably. In patients that cannot tolerate a CPAP machine or an oral device, sometimes we try to see whether surgery is possible to try to cure the patient of the problem. So as you go down from, if you try to do surgery to try to cure the patient, then of course, sometimes it's more invasive because we have to do surgeries to multiple levels to try to open up the airway. So how do we determine which part of the airway is blocked? We determine it through this process called drug-induced sleep endoscopy. Essentially what we do is we have an anesthetist on board that gives you a sedative such that you fall asleep, and we put a scope in to determine exactly which part blocks up at night. And then based on the area of blockage and the pattern of blockage, we can let you know which areas we think need surgery and what the chances of surgery working are. So once we have that plan based on the drug-induced sleep endoscopy, we can do surgery to straighten the septum of the nose, to trim the turbinates, to remove tonsils, to tighten the palate such that it doesn't flop and collapse as much, such that the airway is stabilized. An especially difficult area to deal with is actually at the back of the tongue and the epiglottis area. Like in this patient with a very big lingual tonsil at the back of the tongue. So in this CT scan, you can see that the airway is blocked by this lingual tonsil. Reaching this area at the back of the tongue is very difficult. In SGH, we commonly use the robot to reach this area. In fact, back in 2014, we were the unit that first described its use in Singapore. The overall success rate back then was 90%, and we have greatly more numbers than then, and it is effective in properly selected patients. But, if you've gone on enough forums, you've listened to enough talks, I think a responsible ENT surgeon must tell you that ultimately the success rate of sleep apnea surgery, if you're talking about doing soft tissue surgery, is only between 60 to 70%. So why is it that, even though we try to find out where exactly is blocked and we tackle those areas, the success rate is still not 100%? The reason for this is because if you think about the upper airway and the contributors to sleep apnea, soft tissue is only one component. It must be selected it should only be done in properly selected patients. If the main problem is obesity, where fat is compressing on the upper airway, even if you clear the inside of the airway of soft tissue, the airway is still going to be narrow. Also, in some patients where the main problem is a small jaw, even if we do surgery to the soft tissue inside, the jaw is small to begin with, and the airway is still small and vulnerable to collapse. So take, for example, I like to use this analogy, right? So this is a patient with a small jaw and sleep apnea. Even if we remove all the furniture inside, even if you do soft tissue surgery, still a small airway. So in this group of patients where jaw issues are a problem, what we do is we do maxillomandibular advancement, whereby we cut down the upper and lower jaws, we pull it forward such that the caliber of the airway increases. And ultimately, this is it sounds drastic, but it is a very effective way of treating OSA. This is has been shown through many studies that show that the success rate, 86%, cure rate is high, and longevity of results is high. So just take this example of this case we recently had a couple of weeks back. This was a pre-surgery X-ray, and this is a post-surgery X-ray. You see all the plates and nails that we use to pull the jaw forward. So we did this surgery together with our dental surgeons. This surgery is typically not done by ENT alone. It's a collaborative effort with our dental colleagues from Dental Center. So you see that after we pull the jaws forward, the airway size has increased drastically compared to previous. So are these just all the options that we have? I think what's interesting is what's coming up in the very near future. There's this thing called hypoglossal nerve stimulation, which in essence, it's a bit like those products that you see that work on the principle of electrostimulation of muscles to increase tone and size. Hypoglossal nerve stimulation is whereby an implant is actually implanted under the patient's skin in the chest. And this implant has two wires. one that goes to your intercostal muscles or your rib muscles, and one that goes directly to your hypoglossal nerve, which is the nerve that controls your tongue. So what happens is that patients with this implant would turn on the implant at night before they sleep, and such that every time they breathe at night, a current actually gets transmitted to the nerve that controls their tongue that prevents their tongue from falling backwards and blocking up the airway. So, this device is a very small device that can be implanted, just like a pacemaker, like other devices that are implanted medically, like a cochlear implant as well. This device has been in use in the US and the European countries for about 5 years, actually almost 7 years. 5-year data has been reported with very good sustained success rates over 5 years. So we're hoping that this device comes into Asia and Singapore next year. And so, if you run out of options, you could always come to talk to us. And, if when this device is in, we could discuss whether or not this is something whether it's something you want to consider or not. So the take-home message is that OSA is multifactorial, can be caused by jaw structure, obesity, soft tissue hypertrophy. If you think you have OSA, seek help and let's see what the problem is. It is a major health problem. It has significant long-term medical consequences. CPAP is still the best. I suggest you use CPAP if you can. I use CPAP, but if you can't, then don't give up. There are surgical treatments that can be explored and we can see whether it is suitable for you or not. Yeah. So thank you.
Thank you very much, Dr. Low. I think we learned a lot more about what is different with snoring, sleep apnea, and how it can be treated. So that's the final topic of the day. Now we move on to the Q&A portions of the webinar. Dr. Low is here, that he will answer the question live for you later. But let me just go through the flow from the beginning. To the first question, we go to Dr. Terence Tan. Just give me a second to share the screen. Yeah. Hi, Dr. Tan. This is the first few questions that we have from the Q&A box. Could you address them, please? Yeah.
Okay, so I've been typing away. So all those of you who send in your questions, you can see that I've answered them. But let me just go through them for everyone's sake. So the fatty liver disease generally shows up in your liver panel. That's usually what is it's called in your health screening packages. The test parameters you're looking at, I'm going to give you a alphabet soup, unfortunately, but we're looking out for the ALP, ALT, AST, and GGT. Those are the blood tests that we look at to see whether there might be liver inflammation. Can a blood test alone detect fatty liver disease? Generally not. So fatty liver, as Yasin has mentioned, is a spectrum from simple steatosis, which just means that you have fat in the liver without any liver inflammation, to all the way to liver cirrhosis. So if you just have fat in the liver without any liver inflammation, then unfortunately a blood test will not be good enough to detect that. You will need an ultrasound scan, which is how most patients find out they have fatty liver in the first place. Okay? All right, so how do we get rid of fatty liver? It is the simplest thing to say, but the most difficult thing to do, which is weight loss. I cannot prescribe weight loss. That's ultimately up to your dietary modifications as well as your exercise activity. However, it is the best form of treatment that we know of currently for fatty liver. And what I mean by that is, let's say you start out at 100 kilograms. 5% weight loss, which means 5 kilograms, will reverse any liver inflammation that we see. I repeat, 5% weight loss will result in your blood markers almost certainly getting better. If you have any form of liver scarring, 10% weight loss, 10 kilograms, will get some reversal of your liver scarring status. So it is definitely within your control. However, it is, again, very difficult. Otherwise, we wouldn't have this obesity epidemic that we have in Singapore. Are there genetic factors for fatty liver? There are, but unfortunately, our understanding of the genetic factors for fatty liver is still quite incomplete, mainly because there are multiple genes that code for this. And as such, These aren't usually tested for on an everyday basis. We don't use them in clinical practice. Will fatty liver cause cancer? I believe Yasin has addressed this already. If it leads to cirrhosis, it definitely can cause liver cancer, it can lead to liver cancer. And even if it does not lead to liver cirrhosis, unfortunately, there is still a small proportion of patients with just fatty liver alone, which can get liver cancer without having liver cirrhosis. I think he mentioned this in his talk as well. Okay, so vaccination is good for life. It depends how long ago you got it. If you got it as a child, which most of us did in Singapore, that it is usually not enough for a lifetime. But generally, if you work in a normal office job, you wouldn't really have to worry about a booster jab, mainly because you wouldn't come across the conditions to get hepatitis B in the first place, which is blood-to-blood contact. So unless you're a healthcare worker, then generally you don't really have to worry about a booster jab. But if you're going overseas and you're worried about it for some reason or the other, you can consider getting a booster jab, but do check your antibody levels first to determine if you need it. Okay, I've answered this as well, but basically statin side effects can cause some liver inflammation, so just make sure your GP does your liver panel together with your blood cholesterol checks. Yeah, I'll answer this as well. So basically, if you're seeing polyclinic hep B, generally not. The vast majority of hepatitis B patients in Singapore are uncomplicated, and as such, they only need monitoring with ultrasound scans and blood tests, and the polyclinic is more than equipped to handle that. They will decide if you need to see a specialist if your case turns out to be a bit more complicated than the usual run-of-the-mill cases.
Thank you very much, Dr. Tan. I think that's the question we have for you.
All right.
Let's move on to Dr. Koh. We have some questions for you, sir.
Yeah, hi. Can you see me? Yeah, okay. So is liver surgery the best treatment for liver cancer? The answer is it is one of the best treatments. There are two known curative treatments. The first one is transplantation. The second one I would say is liver surgery. The reason for liver surgery taking second place is that liver surgery, although it can cut out the tumor, it cannot prevent the rest of the liver that's already affected by your inflammation to develop cancer. So yeah. Surgery for liver cancer, what do patients need to look out or prepare for? Surgery for liver cancer is one of the most complex surgeries in the abdomen. It really depends on the extent of liver resection that is required for treating your case, and that there isn't very much that you can do to actively prepare for liver surgery per se, but as with all forms of surgery or all forms of major treatment, you treat it like it's a stress to your body, and you prepare it in terms of good nutrition and good diet and good exercise just before the surgery.
Thank you very much, Dr. Koh.
Thanks.
I think now we have the question for Dr. Edwin. Yeah. Dr. Edwin, please.
So I was typing halfway. So hold on, let me just see the question. Okay, all right. I think some of these questions have been answered in the chat group, but yeah, let's go through some of them. Is there any role for androgen to reduce BPH? I think by androgen, you mean the male hormone. If I were to rephrase your question, perhaps you might be asking, is there any role of androgen deprivation treatment, meaning cutting down the hormone levels to reduce BPH or to reduce prostate enlargement? In general, no. We give androgen deprivation therapy or a treatment to lower down the testosterone level for those patients with advanced prostate cancer or high-risk prostate cancer, because prostate cancer has been found to feed on testosterone to grow and to progress. But we generally do not bring down the testosterone level as a preventive measure, because testosterone is important for you, for your metabolism, for your general well-being, for good bone density, for good heart function, and so on and so forth. It is important. So we only, give hormonal therapy for prostate cancer patients. So the answer is no. For someone over 45, what would be the normal PSA? So there is no real normal PSA, because even in patients with even if your PSA is less than 4, which is within the normal range, you can still have prostate cancer. But because there's no such real normal cutoff internationally, everywhere in the world, we accept anything less than 4 as normal. So for someone whose level is above 4, I would usually offer, depends on the prostate size, because if you have a large prostate, you can have a high PSA anyway, because just by virtue of the volume. But in any case, if you have a PSA of more than 4, I would advise an MRI first nowadays. If your MRI shows that there are no suspicious lesions, maybe you can avoid a biopsy for now, provided your PSA is somewhere between 4 to 10. If your PSA is quite high, for example, if it's 14, persistently 14, even after repeat 6 months, a year, it's persistently high, or if it's rising in trend, then I would be more concerned. Even if your MRI is negative, I would still offer a biopsy, because MRI is not 100% accurate. All right. Okay. If let's say you have been taking, so Deodat has 2 components. Remember, I talked about the medical treatment for BPH. There are 2 main ones, which is an alpha blocker and another kind of a mini hormone pill. So Deodat has 2 of these inside it. One of it is the dutasteride, which acts to reduce your prostate size. But it also artificially brings down your PSA level. So if you've been taking Deodat for a long time and your PSA is 5.2, the real reading is actually not 5.2, it's probably around 10 if you multiply by 2. Okay, so if your PSA trend while on Deodat has been 5.2 for years and years, then I would be less concerned. But if you've just started taking Deodat for a year or 2 and your PSA is 5.2, and if it's rising in trend, then I would be more concerned. I would offer a biopsy, even if the MRI is normal. But if you've monitored it for a long time, then I would be less concerned. I think you can avoid a biopsy.
Okay. Thank you very much, Dr. Edwin. I think we have the final speaker, Dr. Sean Low. These are the questions for you, sir.
Yes. Okay. Hi. So yes, like I mentioned earlier, it really depends what the aim of the surgery was in the first place. Broadly speaking, the purpose of surgery can be classified into 2 groups. Surgery can be used to facilitate the device use. So it could be, you could be doing surgery to reduce blockage of the airway such that the pressures required that have to be generated by the CPAP machine can be lower. So, in those cases where, from the outset, surgery was planned to be done to allow the patient to use CPAP, then I wouldn't consider that a failure. That's part of the original plan to begin with. As I mentioned in the talk as well, soft tissue surgery, where we just deal with soft tissue in the nose, the throat, or the tongue. Overall, the success rate typically is between 60 and 70%. And this limitation in the success rate is actually mainly because in some cases, the underlying problem is not properly addressed. So, if a patient has OSA because he is very obese, even if you do soft tissue surgery and clear the inside of the airway, there is still external pressure on the airway, like the way one would squeeze on a hose. If you clear the hose, but you squeeze on the outside, it's still narrow. So this group of patients tend not to do well, and they tend to end up having to go back to CPAP eventually. So I think, the main thing to highlight is that we need to know what the aim of the surgery was in the first place. Was it to complement a device use? If it was meant for cure, was the underlying problem addressed properly? Because if it is not identified and addressed properly, then it could result in failure and the eventual need to go back to CPAP. Yeah. I hope that answers your question.
Okay, the next one, sir. Yeah.
Oh, yes. Okay, so I have moderate to severe sleep apnea, tried the CPAP, not comfortable. Yeah, so what would be a good approach? I think, the first thing we have to talk about is, are you keen to use CPAP? Because, if you are keen to continue using CPAP, the reason why it could not be comfortable, it could be uncomfortable at this point in time is because of your bent nose. So we know when your nose is bent, when you put on the CPAP machine, airflow through the nose is very uncomfortable and very difficult. So if you are open to trying CPAP, we could actually very well start by just focusing on the nose. We could do surgery to straighten the nose and then try CPAP again to see whether, now that your nose issue is solved, whether it is more comfortable for you to use CPAP. But if your approach is that, you don't want to use CPAP at all, you want to see whether you can try to achieve cure of your OSA with surgery, then it is also important to be assessed by your ENT surgeon, again, to identify what the main issue is. Is it a soft tissue problem? Is it a jaw size problem? Or is it a weight problem? If it is mainly a soft tissue problem, then like I mentioned at the top, what I typically would do is I would then perform a drug-induced sleep endoscopy, whereby we put you to sleep for about 20 minutes with some sedatives, and we try to identify which areas of your airway block up during your sleep. Other than identifying which areas need to be addressed, typically we also look at how the airway collapses, because there are certain patterns of collapse that are not that amenable to surgical correction. So based on that scope, then we can have a frank conversation about which areas need to be addressed and the likelihood of success. Yeah.
Okay, this is the final question for you, sir.
Yes. So yeah, unfortunately, CPAP is not a cure. CPAP, the way CPAP works is that it acts like a splint. It pumps air at a higher pressure relative to atmospheric pressure so that the airway cannot collapse. So yes, you have to hook this up. You have to hook up your mask to the machine. It has to be powered on at night so that the machine can generate that pressure. When you take it off, you're going to go back to square one. Generally, CPAP masks, they do restrict your movement a little bit. There are actually many different designs and interfaces of the mask that you can try on. It is not true that, once you use CPAP, you definitely have to sleep on your back. There are many of us that actually like to sleep on the side, and it's just identifying the best mask that allows you to sleep on the side without causing leakage or any other issues. And yes, unfortunately, like I said, CPAP works as a splint. So if you take it off, you're back to square one. So, if you don't want to go for surgery and you've already been identified that you have OSA, then yes, you have to use CPAP for the long term. Of course, it's not without hope. If your main issue is that you are overweight and that's contributing to your sleep apnea, then, for these patients, sometimes we send them to either our obesity center or we encourage them to go on a formal weight loss program. And once they have lost a significant amount of weight, I will usually retest them to see whether they still have sleep apnea or not. And I do know a couple of patients that after significant weight loss no longer have sleep apnea and they can come off the machine.
Thank you very much, sir. I think that's the final question we have for today.
Okay.
Once again, Dr. Tan, Dr. Ko, Dr. Edwin, Dr. Loh, thank you so much for sharing some insightful information for this interdisciplinary webinar, special focus on men's health to raise awareness for November, the Men's Health Awareness Month. Thank you everyone for joining us today. Okay, so we will have a few more events tomorrow. Do feel free to join us as the link in the chat box. We still have a few limited slots left. So we hope that we can continue this webinar to share more information and awareness with you. Once again, thank you so much for joining and have a good and safe Friday night. Goodbye.